Hello and welcome, everybody. Welcome to another episode of Family Reflections. I'm your host, Keddy Emmanuel. I'm in this call today with Dr. Owen Gabriel, someone who served for a long time as the only oncologist on island in St. Lucia, and someone who has a vast experience in the St. Lucian healthcare system. Doctor, can you tell the people hello and give a quick introduction?
Yeah. So thank you for having me. I'm always happy to share my experiences with others who are interested in improving our healthcare system, both from an individual and a collective standpoint. So as I've operated over more than 10 years as the only oncologist in Ireland, operating at both the Victoria Hospital at the time, St. Jude Hospital, and privately at Tapio Hospital, and now currently at the OKEU H Hospital. So I've had a vast experience where it pertains to dealing with patients and the issues of the system in all its facets, from both the private sector, the urban-rural contexts. And I'm always happy to share these experiences. And as I said before, I'm not the pundit on healthcare, but I hope that what I say will be my grain of salt of sand into the overall picture of things.
All right. And that right there is I really believe you have a unique perspective, given your experience there as the only oncologist for a long time on island. Can you tell us a little bit about that? Because I have heard people speak to the fact that some of the poor experiences that they may have with nurses and doctors may be the result of being overworked and poor working conditions. And I can only imagine that you were working for a long time under a very large, very large caseload. Can you tell us a little bit about how that affected you personally? How have you been able to cope with that?
Well, I mean, I remember in the first instance, when I came into the system, there was no designated position for consultant oncologist on island. So initially, I occupied the post of consultant pathologist in order to be part of the public healthcare system and to have a budget to gain a salary out of. But I did both that role of the head of the laboratory at the Ezra Long lab at the time, as well as consultant oncologist, because the post did not exist
Okay.
in the country's profile of healthcare practitioners at that time. So initially, our first clinics were maybe 5 or 10 people when we first started, and within a year, we had 500 people coming to our clinic on a monthly basis.
Wow.
And that has increased exponentially since, as you would know, that the problem of cancer in the country is vast, and almost everybody being aware of somebody, a friend, a colleague, or a family member who may have had some experience with cancer.
All right.
So the question of being overwhelmed and the workload is, as with anything else in any country, the healthcare system does not run before it crawls. And I think that initially and this applies to in a general sense, that we had to crawl before we could walk. And obviously, as time has gone on, we have had the resurgence of a number of illnesses that were not common before, and the re-emergence of some of these as well. So, for instance, there were times in our country that tuberculosis, TB, was an issue,
All
a
right.
healthcare problem. Then we had the problem of HIV as a healthcare problem. And subsequently, we've had things like diabetes as major healthcare problems, hypertension, cardiovascular illnesses, strokes. Now we hear a lot about kidney failure, and the question of dialysis. And certainly throughout all of these periods, we've always heard of cancer. And obviously, cancer has become more prominent as a healthcare problem throughout. So the question of being overwhelmed is really in the context of what we're dealing with at the time and what kind of personnel that we have available to address the problem.
Okay.
I think in a low resource setting, this would be a perpetual problem of our system about work conditions because of the workload that we have.
Right. And I don't want to derail the conversation, but I'm curious at the mention of a resurgence of illnesses. I'm wondering why that is. Why are we having a resurgence of things that have kind of been put to bed?
Yeah. In some cases, it's a question of vaccines. You know,
Okay.
I mean, some of these infectious illnesses, there were many vaccines developed for them. And if you chose not to have some of those vaccines, then you can have a resurgence of some of these illnesses. I mean, one of the actual ones that there was a resurgence of some time back was TB,
Mm.
that we had put aside because all of us get the BCG vaccine at at 1 month old. I think in the program, if I remember the program correctly, and
Mhm.
subsequently we've had a few years ago, if I remember correctly, maybe last 10 years ago, there was a sort of a resurgence of TB on Ireland, which was very concerning to the public healthcare system and our collaborators, as in CAREC, CARFA, the Caribbean Research and Epidemiology Council, CARFA, the Caribbean Public Health Agency, and PAHO, who were very concerned about the incidence of TB on our island. Especially at that time, we also had the HIV issue.
All right.
So TB is an opportunistic type of illness, so it takes advantage of a suppressed immune system.
Okay. So was that then? Did that start happening because people stopped taking the vaccines? Is that a part of? Did that coincide with the whole vaccine conspiracy movement and people kind of discouraging the use of vaccines?
I would say it would have been multifaceted. That would have been one factor, but also the fact that the kinds of lifestyles that we led, especially with the incidence of HIV on Ireland, those together would have led to somewhat to a resurgence
Okay.
in that kind of illness. It's just an example. There would be others, and
All
so
right.
on.
Okay. All right. Well, today I really want us to see if we can kind of dive into uh first the problems plaguing the main problems, because I'm sure there are I'm sure it's a very complex thing to break down, but some of the main problems facing the St. Lucian healthcare system. And then of course I am very I really want us to look at the solutions, kind of brainstorm on some possible solutions, because I want this to be a solution oriented conversation. All right.
Absolutely.
So just coming off the top of your head, what would you say from your experience are some of the major problems facing the St. Lucian healthcare system?
Oh, well, you asked me for an encyclopedia of answers there. I think if you are just off the top of my head, I would say that I think the first thing that I think that would be a problem, which is a problem for me both at the individual and collective level. Okay, that as West Indians or Caribbean people, we do not have a culture of healthiness.
Hmm.
And I say this in the sense that the term used these days is wellness, a culture of wellness, a wellness culture, let's say. Okay.
All right.
And when you talk about health, health they define as, what we now consider a flawed definition. Health is a state of complete mental, physical, spiritual. These days, you can add economic. You might even add political well-being. Let's say, and we say this is flawed because the health is in itself is a dynamic thing. So once you
Right.
say a state, then it's not so dynamic. But I think the definition puts context to the question of health. So I think the first problem is that there's a lack of personal and individual responsibility for one's own health.
Okay.
So everybody thinks that my health is the responsibility of the government. Now I know we know that health is a right.
Yeah.
But you have a right to education, but you don't expect the government to be studying for you to pass the exam.
This is true.
You have to invest something into your own education. So the facilities for education might be available, but you have to put something in to get something out.
And is it correct? Is it correct there that you're referring to preventative healthcare, right?
Absolutely. Absolutely. Okay. And this is key in our conversation. And I say that the individual responsibility and as a culture, when we compare with a number of Asian countries, for instance, the Japanese, the Chinese, and so on, you see in these countries, health, exercise, healthy eating, meditation, a structured spiritual connection, all of these are inherent to the family as a unit, and then it extends to the society as a whole.
Okay.
So in the society, there are wellness spaces. So you may have outdoor gyms that would be free to everybody's use, accessible to everybody. In your work context, there's time designated for health interventions. Then there are facilities which are made available to the population at large that are health oriented. Okay, so what I'm trying to say here that the cultural context of health is important for us to address it in an adequate way. And therefore the question of prevention, as you mentioned earlier on, is fundamental, because the individual takes responsibility. So you brush your teeth every day because you were taught that if you don't, you will develop cavities and then you have to have a tooth extracted and so on.
All right.
But we don't exercise every day, which is fundamental to health. And we don't eat a healthy diet every day, which is also fundamental to health. So for me, the cultural context of health as a personal responsibility, as an investment, an individual investment in your life and the quality of your life, is absent in our settings.
So is it practical for me to restructure that and say that our culture is unhealthy? Is that a way of repackaging that?
Man, I think culture is a very broad term, a very broad concept.
Right.
But what I'm trying to speak to are lifestyle propensities, the fact that you live a way that is conducive to a positive health outcome.
Right.
So, we define things like diabetes, hypertension, these things, cardiovascular diseases, strokes, kidney failure as lifestyle illnesses, cancer.
Mm-hmm.
We define these are chronic, non-communicable diseases. They're lifestyle diseases. They're not like communicable diseases like COVID-19, coronavirus, the COVID-19 illness that you transmit it to another person. These are things that we bring onto ourselves in greater proportion than otherwise.
Right, the things that are preventable, basically.
That's right. Right.
And I think what you're saying is that we can foster changes in our culture and changes in our families that promote health in a way that we prevent these preventable illnesses. Am I on board?
That's right. That's accurate. That is
okay. All right.
Okay. So for me, that's the first problem we have.
Okay.
In the healthcare system. I think the second one, to my mind, I mean, there are many, but I would prioritize at least three. The second one is the question of a fragmented healthcare system. A fragmented healthcare system. What does that mean? You're aware that we sort of divide the healthcare setting into primary care, which is what obtains at the level of your health centers, your family doctors.
Yeah, you have people say a primary care physician. Yeah.
Primary care physician.
Yeah.
Secondary care, which is what obtains in the hospital setting, where you can do things like surgeries, complex surgeries, administer chemotherapy, radiotherapy, secondary settings. And then there's tertiary care, which is even more sophisticated. Maybe gamma knife surgery of a tumor in your brain.
Mm.
This far more sophisticated. So I think that there's a systematic disconnect among the spectrum of healthcare. So in countries where healthcare operates at the most ideal conditions, the primary care physician is in conversation with your secondary and tertiary level doctor, in the sense like, for instance, a diabetic, one of the complications that a diabetic develops is called diabetic foot, which is that ulcer, that a sore that you develop on your foot that fails to heal adequately.
And that's when people have have to have their feet amputated, right?
Their feet amputated,
Yeah.
and that happens at the secondary level of care.
Okay.
So two things. One would be, if your primary care physician is in dialogue with your secondary level doctors, then we implement strategies to prevent the development of diabetic foot.
All right.
And secondly, one diabetic foot is developed and there is amputation. When the patient goes back into his home settings, there should be communication between that doctor who did the amputation as to what types of interventions would be necessary to control the complications of having had that amputation. So the first one is prevention of the complication, and the second one is dealing with the complication from both ends.
Okay.
Teamwork.
Right.
So I think that there's a conspicuous fragmentation of the healthcare system, that there's no dialogue, there's no communication among healthcare practitioners.
Okay.
Okay.
No, that makes sense, because you definitely want the person who has been working with you over the years and who has been seeing you in checkups to be able to communicate with someone who is going to treat a significant illness, somebody who is going to let's say perform surgery on you for a tumor or something that has popped up, because you definitely want the person to have the long-term context of who he's working with, right?
That's right.
Yeah. Okay. That makes sense to me.
So that's the first question of the fragmenting of the healthcare system. The second part, I think, is also the question of what obtains between public and private care.
Okay.
So there's also a disconnect, public and private care.
Help me break that down.
So the general sense is that private care is better than public health care. So if you go to a private hospital, the quality of the care is better because you're paying for it.
Oh, yeah, and I think I've definitely heard that sentiment shared. People will say, "Oh, if you want good care, go to Tapion." Don't go to, let's say, St. Jude's. People always seem to put private care on a pedestal.
Or further, go overseas.
Yeah, overseas. Yeah,
because the local healthcare system is not adequate enough to deal with your problem.
right.
So I think that the issue here is the absence of national standards for healthcare, which means, where is the bar? And the bar should be the bar for public and private.
Yes.
Where is the bar? Where do we set the standard for quality healthcare? There should be a basic level of quality interventions that exists whether you go to public or private. Now, there could be more resources available in the private sector, which is natural, but the quality of healthcare should entail a number of interventions that should be executed at a certain level of quality that should never drop below a certain standard.
Right. Okay.
Never drop below a certain standard.
So, isn't it true that the St. Lucia Bureau of Standards should have some sort of say in that, or have healthcare standards mapped out?
I've actually been part of the Bureau of Standards many years ago as part of one of the caps I wore. I sat on the board of the Bureau of Standards many years ago, and I can
Okay.
tell you they're overwhelmed with just trying to put standards in order for the basic common issues. Your gas your gas pump, making sure that the amount of gas you get is the correct one on the registered on the dial, on the
On the
gauge,
meter.
meters and so
Yeah.
on.
All right.
Just basic standards of weights and metric and calculations and measurements and so on. Food labeling. There are numerous issues that they involved in, and I can guarantee you the question of standards in healthcare is very complex, something that has not been ironed out. Even the best among us in the world, obviously in the UK and the US, you understand healthcare is a major debate,
Right.
different settings. So, but we do have to work on these standards for healthcare. So when you go to a doctor in his office, there should be basic standards of care and facilities and resources available that should never be missing to offer care to somebody, and it should be across the board. So when I go to a doctor in Cap Estate, it should be no different in the quality of care that he offers me to if I go to a doctor in Castries
Right.
and
It's
anywhere
true.
else. Okay,
It's true.
so I think that there's a disconnect in the quality of and the standards of care offered in public and private as well. So that's
Okay.
the second part of it.
All right. And that makes sense. And folks, if you've been following, you know that we just went through cultural influences or lifestyle influences in terms of uh, problems with the healthcare system. And then we talked a little bit about the fragmentation between primary, secondary, and tertiary healthcare. And now we just spoke a little bit about standards and uh, the difference between private healthcare and the public healthcare system, right? Is that correct, Doc?
Absolutely, that's perfect. And thirdly, as far as this is concerned, I think there's also a question of regionalism, let's say. So there's a perception there that healthcare in the north is different to healthcare in the south of the island.
Okay.
And again, historically, the healthcare institutions have come through different channels. In the sense that, for instance, the St. Jude Hospital, which is our representative of the symbolic representative of healthcare in the South, came up through a system where it was run by a charity of nuns initially, and eventually transformed into a public health institution, and now it's run by it's a statutory organization run by a board and so on. So the question of resources has varied throughout its lifetime.
Right.
Whereas in the North, Victoria Hospital has always been a public health institution where the resources for healthcare have always been focused. And it obviously had lived its lifespan and has now been transformed into the COVID-19 respiratory hospital for the purposes that we all know of now. And now we have OKEU, a new hospital with which may have inherited some of the ailments of Victoria, in spite of the fact that it has new walls and new structures and so on. So I mean, this will come down to the third plague that I think when I speak of it in a while. So there's also a disconnect, and I think this is because of lack of national standards for healthcare.
Yeah. And going back to St. Jude, I could imagine that the transfer across the years with exactly how the institution has been functioning might really take some growing pains with the institution transitioning out of, being a charitable place into a public facility, so I'm wondering if that might explain some of the growing pains that I've personally seen along the way. Um, but
Absolutely.
yeah, St. Jude really has a place in my heart because that's where I was born, you know. that's where that's where my grandfather passed away and my grandmother passed away. You know, it's where my family has been treated historically, and so I really want to see St. Jude's thrive, and I'm very concerned with the way things are right now. I really want to see things improve there for sure.
Oh, definitely. So, um, the third part I'd like to speak of is a more is a broad context of overall national development. Let's say, okay. I think that one of the main problems of healthcare in St. Lucia is the absence of a national development plan. A national development plan. That
Okay.
is to say, a structure that is evidence based. And let's say, for argument's sake, let's say a 25-year span, a, a whole, an integrated, holistic vision of national goals, which are then tied into the resources that are available, the resources that may be sourced, that would be associated or correspond with projections in population growth and these illnesses that may come about, whether we'll have an increase in these non-communicable diseases or those communicable diseases. Taking into context the influence of contingencies in shortfalls from environmental disasters, the hurricanes that we face off and on, as well as the fluctuating uh, successes and achievements in things like tourism.
Mm-hmm.
Okay, so I think a national plan looking at the economic, social development of our people as a whole is important for a robust, sustainable healthcare system. And to do that, you have to put people at the center of it as our most important resource. And if you
Right.
put people as our most important resource, then health of the people becomes a priority. So for economic growth, we must have health of the people, a healthy population.
And when you say it, it sounds so straightforward. It sounds like something that is very much an of course you need that. But unfortunately, I think people forget this. I think people administrations seem to get blinded with other things that require attention and tend to not put health at the forefront. And yeah, I want to really emphasize the truth of that statement. You need people to be healthy. You need people to not be afraid of getting sick. And yeah, I really want to strongly agree with that.
So I mean, down the line, people will talk about the availability of resources for healthcare.
Right.
Now, because healthcare, like education, is a non-productive sector, we're not agriculture, so you can't sell bananas and get returns, that you can reinvest into the sector. It's a non-productive sector, but non-productive in what context, really?
Right.
Because you can't have a sick farmer either, because
Exactly.
he will not produce.
Right.
So you want to have a healthy farmer or a healthy tourism, worker, hospitality worker. So health is at the core of economic growth
Right.
as well.
Yeah,
At the
and
core,
sustainable productivity.
absolutely, absolutely.
Yeah, because people forget that uh if someone gets sick, it's not just this person's productivity that is lost. It's not just this person who loses a day of work. It's also this person's brother, this person's mother, this person's father, who now have to go to the hospital and miss a day of work, sitting in the waiting room. They're concerned, they're emotionally impacted because now they're worrying about how their loved one is going to be doing, what's going on with the person that they care about. And so the loss of productivity is a web. It's it's a far-reaching web, because even beyond the immediate family or the people immediately impacted, these people have co-workers. These people have spouses and boyfriends and girlfriends, husbands and wives, who now have to come in and try to help console them. So there's a far-reaching impact when just one person is sick, when just one person is unhealthy, because we're all connected.
So I mean, when people do public health, I imagine there is a subject might, health economics, that delves into those areas that you speak of, as to the impact of one person being sick for a particular illness on the entire system,
Right.
of the society. I mean, I did a study a few years ago called the burden of illness of gastrointestinal diseases, which is diarrhea, for instance,
Mm-hmm. Mm-hmm.
vomiting, diarrhea. Uh, and we were able to show that if a person got a foodborne illness, which is what sometimes causes those gastroenteritis, you eat a food that is spoiled or toxic, it has some pathogen in it, E. coli and so on.
Yeah.
And that person decides to take, home remedies, for instance, or B, take antibiotics off the shelf, because a friend has amoxicillin at home, or, and so on. And versus a person who first goes to their GP gives them sick leave for 7 days. Then if they get if they're if it's a child now, the child stays home for a week, the person has to hire a sitter to take care of that child because they have to go to work.
Yeah.
um, then the cost of all the interventions of the tests that you have to do, uh, going back to the doctor for the result of the tests and what you pay for that because you went the first time already, um, all the issues surrounding just having that one illness. And we were able to calculate that in the millions of dollars if you calculate the burden of all the gastroenteritis that people develop in St. Lucia annually, usually during the rainy season. That many people either stay home from work because of this diarrhea and vomiting and so on, and their children stay off school, and therefore they have to hire somebody to stay at home with that child, or put them into a daycare or whatever the case may be and pay for that, pay for the medications. So there's a cost, and there's a hidden cost that we do not know of, because all we see you paid the doctor $150,
Right.
but there's so many other things that are involved and incorporated into that illness, that one person being ill. And if you multiply that one person by 100 people, and the salary of the doctor if you go to the public healthcare system, and the salary of the nurse, the salary of the lab technician, the salary of the x-ray technician, all of these things have to be included in that one person.
Yeah. So I think the takeaway there is that healthcare is very significant, and it pays to pay attention to this. It pays to prioritize this, and we need to see a little bit more of that in St. Lucia, in my opinion.
Oh, absolutely. Unfortunately, oh, and this is hard for me to say. The persons that we have who are responsible for the policies of healthcare tend to ignore the real issues because they're so overwhelmed with the daily crises of healthcare. the
Mm-hmm.
daily issues that confront them. They
Right.
do not look into the root causes of the issues enough
Right.
to tackle it from a causal cause-effect relationship, you
Right.
know.
So basically, there's so many small fires that all the time is spent trying to put out the small fires, but the source of the ignition is difficult to
Not,
actually address.
yeah,
Yeah.
yeah, and so on. I mean, I think it really takes us to take stock of what we want for our country as a whole. I'm saying this, and obviously there's a bias. My emphasis is on healthcare because that's what I deal with.
Right.
But we need to look at the balance of things. You know, how one thing impacts another, and what's the interrelationship of everything, of our education, because our education could be responsible for developing the culture of health, of lifestyle. If we teach our children from the very onset of their education that it's important to be healthy. I mean, there are numerous studies all over the world that look at things like nutrition and educational performance. So you're able to show that a child who has a healthy meal or 3 healthy meals a day outperforms another child who is lacking in that respect.
Yeah. In fact,
And
there's a I just want to push in this story ahead. There's a teacher that I know very well who was telling me how she punished a student once who hadn't turned in his homework. You know, he seemed delinquent. He seemed like he wasn't paying attention to his work and he hadn't turned in his homework and he was punished. And then after he was punished, she asked, Why didn't you turn in your homework?" And he says, uh, I haven't eaten. Um, I'm hungry, you know? And that really stuck with me when that story was shared with me.
yeah,
So that speaks to the nutrition part of education for
absolutely,
sure. Yeah.
absolutely. And I mean, when we went through school, we knew that beating was the remedy for lack of performance.
Right.
And I mean, now we know that some people were dyslexic, for instance,
Yeah.
and probably a lot of these cases were cases where the home environment was just not conducive to performance in the classroom, whether it
Right.
was emotional, psychological, physical abuse, or malnutrition.
Right.
All of these could, would impact on the performance of a child.
Yeah.
And, and,
Absolutely.
and think about what the long-term effects are in a society. That person becomes a citizen and they were not able to be fully, let's say, realized, the real self-realization. And now they are failed, they are deemed failed persons in our society.
Yes.
Um, and then they say seek other avenues for self-expression to make it, because they have to feed their families either way.
Yeah.
Whereas,
And no, I was just going to say that itself becomes a cycle in and of itself.
that's right. That's
Because
right.
that person then will very well have children, and those children would also be placed in a similar situation that this person was placed in, and those children would also be similarly disadvantaged and never actually fully reach their full potential.
That's right. That's right. So I mean, a lot of the health issues are not them always organic. A lot of our health issues are sometimes social factors, socioeconomic factors that impact on us, that lead to these outcomes that we have in some cases. And obviously, I mean, obviously, cancer is one of those very glaring examples of where that obtains.
Right.
So, I mean, many years ago, I remember treating patients for prostate cancer. Now, prostate cancer generally is a type of illness that affects older men. The literature says 70, the average age of 70 and above, and so on. However, we found that in St. Lucia, younger men were getting prostate cancer.
Hmm.
Now, when the prostate cancer develops to such an extent that it becomes resistant to the common levels of affordable treatments, about 10 years ago, there was this one drug, a wonder drug that was injectable, but at that time, it would cost something like 5,000 EC per 3 month supply. 5,000.
Wow.
So I found that my older men who had lived their lives, had been successful businessmen, had their savings intact and so on, appeared to be doing better because they were able to afford the medication. Whereas our younger men who should have been doing better, but because they were so young and had not had reached full potential and these savings, were unable to afford that medication and therefore perished faster than the older men,
Wow.
which should have been the reverse.
And right there, that's so striking to me because I don't think it really bothers me that people pass away because they don't have the money. They don't have the money to buy treatment. That really bothers me.
Absolutely. I would say that, I mean, that is a major factor in almost all our illnesses. In spite of the fact that, we try to implement universal health care for diabetes and hypertension, we still have persons with major obstacles to paying for medications. And in a way, we created our own monster,
Right.
in a way. Because if you go to St. Jude Hospital or OKU or Victoria, and you've been prescribed antibiotics, the doctor prescribed a week of antibiotics or a month supply of antihypertensives and so on, you probably pay $5 for the whole prescription. 5 EC dollars for the whole prescription. So you take that very prescription, that same one, and you take it to a private pharmacy, and you're now paying $75, $150, depending on what it is.
Yeah.
For the same drugs. So what happens as a consequence is that in the public health facilities, you have paid $5 for something that costs $175. So eventually what happens is that in that pharmacy, you come back 2 months later and they no longer have that medication.
Yeah, because the it was so far underpriced that everybody just bought it up.
So everybody now complains, oh, they don't have this medication in the pharmacy. How come they don't have this medication? Well, because you didn't pay a suitable amount for it, of the true cost. True cost, a suitable amount of the true cost for it. Now, I mean, there are pros and cons to this. But the fact is, healthcare is also expensive.
Yeah. But hold on. Let me just clarify something here. In the case where this person is paying $5 for a $175 thing, who's footing the rest of the bill? The government?
The government is footing the rest of the bill.
Oh boy.
The government is footing the rest of the bill. And that's why the government is unable to sustain the recurring costs of these medications. And in the OECS, we have something called the Pharmaceutical Procurement Service, which means these OECS countries put money together to buy medication in bulk so that it's cheaper. Notwithstanding the savings they make buying in bulk, it's still more costly than what it's been sold for.
Wow. Okay,
so we have.
I'm just asking, and we have these problems that I wanted to tackle the solutions to. We might have to revisit that on maybe a second part of this conversation, possibly. But I really want to know how are those drugs priced? Like, who's deciding that this thing costs $5? Who's setting up that retail price?
Well, unfortunately, there is no strategic cost setting. It is just $5 because it's a prescription in the public sector. It does not matter what's on that prescription. Or $10.
That doesn't sound right at all. Yeah, that doesn't sound right.
There is no correlation with market price and this and that and the other and so on. It is $15 or $5 or $10 because it's a public health prescription. Well, regardless.
That sounds like almost an unofficial, unestablished health insurance system, national public health insurance system. That it sounds like it's already there. It's just informal, you know.
That's right. Now the problem. This is great stuff. You want a national healthcare system, but who pays for it? Because so in these developed countries, Finland, Sweden, and these places, the taxes on your salary is almost 50%. Almost 50%. But you have free health, but free quality health,
Right.
free education, free quality education from birth to tertiary education all the way through. But it is sustainable. Now, in a country where our unemployment is like 25% or whatever it may be in the different age groups and so on,
Right.
and you have the persons with higher incomes paying for the majority of through the taxes and so on. So it's a vicious cycle, a vicious circle, because you have high unemployment, so therefore there's a minority of persons contributing to the taxes and so on, and then you have high cost of healthcare.
Right.
So we need to find the balance.
Yeah.
And for me, the balance would have been something like a VAT that is all encompassing.
Right. A tax that basically covers everything there.
And everybody pays into it. Everybody.
No.
So in our country, there are a number of sectors that don't pay any income tax because they just don't fit into the brackets,
Yeah, they have an exemption.
Yeah. I mean, not even just the exemption, but there are some people who just won't pay taxes because, the line of work is not considered,
Taxable.
I mean, there are groups that I mean, I don't know if, for instance, taxi drivers pay taxes, bus drivers pay taxes. I don't know. These heavy machinery operators or these tents and these kinds of person who pay taxes. I don't know, but
yeah,
you
I can't speak
that
to that either. But I understand the point you're making. Yeah.
Yeah. So there are large sectors that don't pay into the taxes, but use the facilities and resources that we have available through that national insurance system.
Yeah.
So I think we need to refine our structures to ensure that there's an equitable format of resource revenues versus what we expenditure.
Right. So
Something
basically, we need to outline what we're making and how we can spend it in a productive way regarding our healthcare. And I think that's a very good point. And it may involve some tax reform, which is what I think we're agreeing on there. Going back to some of the original issues that you mentioned, just speaking from the perspective of possible solutions. When you talked about the fragmented healthcare system, and that is for those of you who have just joined us or didn't catch when we originally went through that, it's basically the disconnect between primary healthcare, secondary healthcare, and tertiary healthcare. How do you see us generating more continuity between those segments?
Well, I think it's a difficult task, but it's something that's doable. I think we need to develop a national health plan. So the health plan would say a patient with diabetes living in the community of Montfortune will be seen by his primary care physician once every month for these basic tests. If the results show such and such a thing, the patient must be referred to the secondary healthcare practitioner who is available twice weekly at such and such a place. He will do these tests, which will cost such and such an amount, and whatever the case may be. And then the results of which will be managed by him in that respect and by the primary care physician in that other respect. If the patient develops a stroke, for whatever reason, that patient is then referred to the specialist who can then do stroke management, whether it's whatever intervention it is, it's surgical, it's whatever. And that is done by, and then when he's done, rehabilitation must occur in the primary care setting with your physiotherapist and your speech therapist and your this and that and the other. Yeah. So you see how we've gone through the circle, and we've gone, there's a flow. But the flow must be documented. Yeah. It has to be in there so I know the role I play. Yeah. And the patient has, is aware of the flow. The patient, the family, the insurance provider, and so on and so on.
So as a techie person, what I heard there is the potential for implementing some sort of data management system in St. Lucia where patients' medical records are available across the island. For example, let's say if someone originally went to a primary care physician at St. Jude's, right? And eventually that person has some sort of brain tumor, right? That person's medical records would be available to the surgeon who's about to perform this tumor removal. And then that person could say, oh, this person also has heart problems. This person also has this. And that would then be immediately available. And so I think that might be able to help with that flow between the segments. Would you agree?
Absolutely. That is exactly what we're trying to discuss here. The problem of communicating for the benefit of the patient. The patient must always be at the center of our interventions. The patient must never, not benefit from what we do. And the only way they can benefit is if we speak to each other, if we dialogue with each other. And that health information system supposedly exists in our setting, supposedly. But it exists at a very rudimentary level where it's just data. Right. And numbers, which is a pet peeve of mine with the whole coronavirus issue, where numbers are just numbers and not analytical data. So, right. If there are 1,000 cases, it's just 1,000 cases, but what does it mean to me?
Yeah. And data is worthless unless it's actually processed.
Absolutely.
Data, in order to become information, data has to be processed.
Absolutely.
And no data management system is useful on its own, right?
Absolutely. So that connection, we must be able to connect the dots. And you're so right, because if you're going to do surgery on somebody, but you don't know that they have an underlying heart problem, the surgery will fail. Right. Because you'd have gone in there and you didn't realize that this person has unstable angina or whatever the case may be, and you have a problem in the operating room. So we need to get, and the problem, what I'm thinking is this is like people say, I say, so people say a 2x4 country. I usually say it's a 2x2 country, and so on. And I
what
say
does
this
that mean?
No, that means that we are so small, it should be manageable.
Okay, yeah.
There's 180,000 people here.
Right.
We have, I've always put this example, currently I think we have 6 healthcare facilities, between Victoria Hospital, OKEUH, Tapia Hospital, St. Jude Hospital, Denry Hospital, Soufrière Hospital. 6.
Right.
So we have 180,000 people. Let's go to Martinique. Martinique has about, whether it's 300 or 400,000 people, 400,000 people, close to 400,000 people, 1 major hospital. There are good satellite clinics and polyclinics, but 1 major hospital.
I didn't know that.
Barbados, 270,000 people, Queen Elizabeth Hospital.
Good polyclinic in Barbados?
1, yes. 1, good polyclinics, good private clinics, and so on, but 1 major hospital. Trinidad, 1.3 million people, fundamentally 2 major public health institutions, wow. Port of Spain General and San Fernando General. 1.3 million. Million.
All right. So right
We
there,
have seen.
it sounds like we need to consolidate a little bit. It sounds like we need to consolidate and really just boost our use of our polyclinics and health centers.
That's right. That's right. So there needs to be reformatting of the structure of the healthcare system, and it takes, analysis. What are we dealing with? What are our goals? What do we hope to achieve? What is the density of the population there? What are the most common pathologies there?
All right.
How can we share resources and so on? It is not rocket science. This is not rocket science. This can be done. It just takes somebody to sit and put it on, experts in different areas of things and just bring the thoughts together. This can be done.
Right.
At least it can be better.
All right.
Because say we're not aspiring to perfection, we just want something better. It can be done. It can be done.
And I'm hoping that it will be, because it has to, right? It has to. We have to. And as much as it's easy to ignore uh healthcare when you don't need it yourself and nobody you love needs it, the time will come for every single one of us, where we have to take it much more seriously, because we're the patient. We are the ones being affected. And unfortunately, I think very often for some of the people that have the power to change the system, for some of the people that have the power to really make things better, they also are usually the people that also have the resources to leave and go to another country for care. And so I think the ball gets kicked down the road, because those people aren't usually affected in the same way that other people are, who do not have a choice, right?
Absolutely. It's unfortunate. I mean, so I think we are drowning in a teacup. I mean, there's a sense that we say we are overwhelmed with health, but if we look at the basics, the very fundamental issues, we should be able to address them with nice preventative health care.
Right.
Uh, and I think it entails an educated population in the first instance. Do we know what it means to be healthy and what we can do from our own personal responsibilities, personal interventions, and how we contribute towards the national goal of
Right.
health for
Right.
all?
And I think that's getting better, right? I feel like the St. Lucian populace is far more educated now than we have been in times past, and
Absolutely,
and I think that trend will continue forward.
absolutely. I mean, again, the teething, growing pains. I think you said earlier on, growing pains. And but you see, we have growing pains, but we also need to be able to project and anticipate. Let's not just have the growing pains and suffer the issues of the growing pains, but let's understand what it is that we want as an output,
Right.
you know, because we know we're going to go through the growing pains, but we need to um, what do you call it? Classify our problems in terms of priorities, immediate, long-term goals, and so on, and
Yeah.
then tackle them strategically. How we
Right.
can um, merge resources, merge expertise, so we it's cost effective and it's efficient in the long run.
Right. Right. And I think the place to start with all of those is really prioritizing this. Really looking at this and realizing, okay, this is something that needs our attention. And particularly speaking to the government administrations, and I don't care whether you're UWP or SLP, whoever is in power needs to prioritize healthcare in St. Lucia. And we need it. It's not a want, it's a need. And I'm hoping that this episode will at least serve to boost the conversation surrounding healthcare in St. Lucia. And I want to thank you so much for taking the time to join me on this episode. Of course, there's so much more that we could have talked about. There's so much more that we could have tackled, and there's always the possibility that down the road, if you're willing, you can come back and join us again to hash things out. But yeah, I really hope that this conversation doesn't fall on deaf ears.
Well, I was just getting warmed up. I was hoping we have like another 4 hours to go and so on. I just hope that this is a clarion call, and it emanates from the layman, that we're so concerned about our loved ones, as you put it, that we want to make sure that they have the best opportunities to survive.
Yeah.
And I think the first step is to looking at this as a national problem and coming together. We structure a 25-year plan as to, well, in 10 years I have to build 2 more polyclinics. I have to build 1 more hospital. It has to be like that. If not,
Right.
whichever government is in power, it does not matter. You cannot deviate from the course of action, the
Right.
road to the goals, regardless of whichever government is in power. But this is the plan, because it has been studied, it has been researched, and we know exactly how we're going to achieve those things that we have said that we want to achieve.
Yeah. Absolutely. It can't be something that drops and wanes from administration to administration. It has to be
That's
something
right.
that remains consistent.
Absolutely.
And I really hope that this conversation boosts the possibility of that being the case. So, folks, if you're watching this and you're still with us, share this to and tag someone that might need to hear it. Tag someone who might have a say, and let's hope for the best for our island and for our people and for the ones we love. All right. Uh,
Absolutely.
Dr. Gabriel, thank you so much for joining me. Folks, you will see my face again on March 15th. March 15th, we'll be back again for another episode of Family Reflections. Thank you so much for joining us. I have been Ked Emmanuel, and he has been Dr. Owen Gabriel. Thanks for joining us. Bye
Thank you
for
for
now.
having me. Anytime.